This is an in-service training program presented by Discharge. Today's topic, clinical documentation. Today's learning objectives: number 1, understand importance of proper clinical documentation. Number 2, understand what information is needed for a resident to receive an accurate assessment. Different types of documentation. Initial assessment is the base assessment where goals are established. Quarterly, are we or the residents meeting their care plan goals? Readmissions, this is where anything has changed. We would note that. Significant change, what has changed? Are they a new tube feeding, hospice? Discharge, status of discharge, care plan up to date, any education? And then annual assessment would be another base assessment. Resident assessment, or F636, comprehensive assessments to be done within 14 calendar days after admission and no less than every 12 months, excluding readmissions in which there is no significant change in the resident's physical or medical condition. When there are triggers in the CA, there's to be an assessment or documentation regarding those specific triggered areas beyond the information in the MDS. The CA is to be used to help assess the root cause of these triggered areas. Also consider doing a progress note or other assessment tool to try to determine or assess and then describe the root cause for these triggers. Documentation by food and nutrition services and/or a qualified dietitian or other clinically qualified nutrition professional is to include that the resident was seen, talked to. Make sure recall residents are to be told of their nutritional status even if they don't seem to comprehend. Interviews for assessments are to include the resident plus staff members from all shifts. Accuracy of assessments, F641. We must assure that each resident receives an accurate assessment reflective of the resident's status at the time of the assessment by staff qualified to assess relevant care areas and are knowledgeable about the resident's status, needs, strengths, and areas of decline. When doing an initial assessment, make sure you read the medical record for history and physical, summary discharge, notes, dietitian documentation, perhaps from another facility or a hospital, what diet they were on, diagnosis, medications, height, weight, their BMI was, anything that interferes with intake. For example, they don't like table mates, they have an arm in a sling, what their percent intake was, any labs, skin issues, edema, fluid loss or retention, any speech or swallow evaluations, or anything unusual. They were on a tube feeding or TPN, and then what their care plan was at the hospital or other facility. During the interview and observation stage, ask the resident or family if their weight is usual or if they've experienced any undesired weight change in the last 30 or 180 days. Does the resident or family member report lower than normal appetite? What about, do they have their own teeth, loose-fitting dentures, and then their eating ability? Independent, do they need assistance? Other questions to ask, are there special adaptive devices such as plate, cups, glasses needed? Preferred meal location, the usual meal times for breakfast, lunch, and dinner, any likes or dislikes or allergies or intolerances, ask for the beverage preference. Also ask if there's any cultural beliefs that the facility should be aware of. Observe the resident at meals, activities, maybe the ice cream parlor. Observe in their room. Do they have snacks? How much are they eating? Observe if they have any food that's eaten or uneaten, whether it's facility, fast food, supplements. General appearance, are they robust, thin, obese, muscle wasting, conscious, or any debility to hand or arms? Make sure to ask the resident or family what their nutritional plan is. It's a resident-centered care plan. What do they want to achieve? Are they willing to do their part? Use the continuation of care plan as a basis. Help to utilize what you know of the resident and helps to guide the resident in the nutritional plan. Opportunity for nutrition education. Handouts are very helpful. Also can prevent rehospitalization after admission and also help prevent rehospitalization after discharge. Make sure you document that the conversation or education that did happen and include the time or date of the interview or education. Conclusions with your assessment. You've got your information gathered from records, interviews, observations. Complete your assessment tool, the MDS and the CA, and determine the nutritional status, nutritional risk score, etc. Quarterly review, F638. Compare the nutritional status at the quarterly with the last written care plans to see if there's any change. Do the approaches need to change? Do problem strengths need to change? Do Do the goals need to change? Resident family are to be involved with the quarterly assessment process and have a voice in the plan for caring for the resident. Here's a sample progress note for a quarterly. See nutritional assessment for history. Resident was underweight at admission, related diagnosis. Now with significant weight gain related to improving PO intake. Weight gain is planned, desired. Care plan remains relevant. Another example, see nutritional assessment. You would insert the date for history. Resident was underweight at admission, related diagnosis. Now with improved PO intake has achieved goal weight of 145 pounds, bringing BMI to normal status range. Desire is for weight without unplanned, undesired, significant, or trending changes. Care plan adjusted. Recommend DC fortified foods at all meals. Continue with double portions or double protein at breakfast as a food preference, not an order, as resident enjoys it per interview. Readmission assessments, typically shorter assessment, depends on where you work. Sometimes it might be another full assessment. You're going to compare to their previous status, see if their nutritional status has changed or not. Review the hospital record as far as hospital diagnosis, anything different, diet or eating ability, new tube feeding or TPM, weight changes, skin, medication changes, and then the interviews and observations. Significant change, F637, in a resident will typically be identified by nursing or MDS. MDS will typically notify those who need to conduct a significant change assessment. Full assessment includes chart review, interview, observation. We have a NAR meeting. There's a new baseline. The reference will now be to that assessment, then adjust a care plan if needed if the resident goals have changed. Discharge summary F661. When the facility anticipates discharge, a resident must have a discharge summary. MDSs and CONs need to be done as scheduled, as they are used to prepare the discharge summary of a resident's status. At the time of discharge, that includes the resident's nutritional status. Care plans need to reflect any nutrition-related plans the resident has for discharging, for example, eating for glucose control or weight control. Residents may want or need instructions on how to shop for food or meal plans around their medical condition when they leave the facility. Food and nutrition services may need to provide written instructions as well as verbal instructions to the resident or resident representatives on the nutrition-related need prior to discharge from the facility. This also may help in preventing rehospitalizations after being discharged home. Annual assessment is a full assessment similar to the initial or significant change assessment, but the difference is now you know the resident. Make sure you read the record again, observations, interviews, routinely review, adjust the care plan, and you can basically summarize the year in review. And then in between progress notes would be charting that occurs in between charting times. Observations, if the care plan needs to be changed, additional care plans need to be written. Are the interventions working? Also any conversations, any referrals, eating changes, wounds, or weight changes. Let's take a short quiz on clinical documentation. Question number 1. The different types of clinical documentation include A, quarterly, B, significant change, C, initial, or D, all of the above. And the answer to question number 1 would be all of the above. Question number 2, reading the record includes A, diet, B, dietitian notes, C, labs, or D, all the above. And the answer to question number 2 is D, all of the above. Question number 3, interviews and observations include A, observe at meals, B, observe the resident's room, C, look at their overall appearance, or D, all of the above. And the answer to question number 3 is D, all of the above. Question number 4 is true or false. Doing discharge charting will not prevent rehospitalization after being discharged home. And the answer to question number 4 is false. Discharge charting may help prevent rehospitalization after being discharged home. And question number 5. Resident family need to be involved with the quarterly assessment process and have a voice in the plan for caring for the resident. And the answer to question number 5 is true. Thank you for your participation in today's program. Our goal is for you to use this information in your daily work. We hope you are well served today and every day. If you would like more information about our in-service training programs or consulting dietitian services, please contact us at 1-800-761-9200 or nutritioncaresystems.com.